Right. Assalamualaikum and good afternoon, and welcome to this webinar today. And thank you for taking the time off this afternoon. As you know, it's the Ramadan month, and most of us are actually fasting. So if you find that my voice gets a bit soft towards the end of the talk, please forgive me because my throat will get dry with all the talking. So I'm going to talk about protecting Malaysian children against pneumococcal disease, and these are my disclosures. I'm not employed nor have shares in any of the companies that I've been involved with, and I am not an employee of Pharmaniaga either. Now, what we're going to do today is I'm going to talk, the first half of it is a bit of a storytelling about what pneumococcus is and what damage it does and what's the disease burden in the country. And then I'm going to introduce you to one of my patients, and then we'll go on to talking about, I'm going to share the journey that we've had in introducing pneumococcal conjugate vaccine in the country from 2005. And then we'll talk about, and then the hard stuff will come after that on the PCVs in Malaysia and also the new 10-valent PCV and also newer PCVs in the pipeline. So we all know that Streptococcus pneumoniae is from our microbiology days is a gram-positive diplococcus. It has a polysaccharide capsule, which actually provides a virulence factor, and there are more than 90 serotypes. And some of the serotypes are more prevalent than others. Some serotypes are more prevalent in invasive disease, and the serotype distribution differs by country, region, as well as time. And the vaccination is very serotype specific. So we know that in the country we have the 7-valent, we had the 7-valent conjugate vaccine Prevnar before. Then we had 10-valent conjugate, which is the Synflorix, and then 13-valent Prevnar came in after that. And we also have the polysaccharide vaccine, which is the 23-valent one. And then now we have the 10-valent pneumococcal conjugate vaccine or Pneumosil. Just to make it easy for you to understand, I'm going to use the terminology that my friend Nitin Shah used before in referring to Synflorix as PCV10 and 10-valent conjugate, 10-valent pneumococcal vaccine as Pneumosil. So a bit of revision, pneumococcal disease manifests itself in either, for simplicity's sake, divided into non-invasive or mucosal disease and invasive disease. And non-invasive disease is sinusitis, otitis media, as well as pneumonia, non-bacteremic pneumonia. Now, in the invasive disease, this is where you get bacteremic pneumonia and empyema, and then bacteremia and meningitis. For children, in children, the majority of the cases are acute otitis media followed by pneumonia, and then the tip of it is meningitis and septicemia. Whereas for adults, it is mainly pneumonia, whether it is 2/3 of 3/4 of which are non-bacteremic and 1/4 is bacteremic pneumonia. Small cases at the top, which are meningitis, usually in patients with comorbidities. Now, we know that the incidence has got a U shape with a peak in the younger age group and the older age group, but mortality actually goes up as age with age. So in 2009, WHO states that of the estimated 5.8 million deaths among children less than 5 years, 290,000 were estimated to be caused by pneumococcal infections, with 100 children dying every hour and 1 to 2 child dying every minute worldwide. I'm going to introduce you to my patient for a short while. This is just to show you the presentation that the pneumococcus can come with. This is a baby that was born in our hospital in 2010, August. And he came back for his hexavalent vaccine, which is the DTP IPV Hep B at 2 months old. And during that time, the additional recommended vaccines, including pneumococcus, also informed to the parents. Then they disappeared, probably because maybe they thought my charges were too high, so they went to see the government clinic, or probably went to see one of the GPs to continue with the vaccination. Now at 7 months, he came with fever on and off for a month, with cough, running nose for a week, and there's noisy breathing for 5 days. His temperature was 39.8 and he was breathless, chesty, with the trachea obviously deviated to the right, with a respiratory rate of 45 per minute, and there were crepitations and decreased breath sounds in the left lung. His saturations were 90 to 92. He had a leukocytosis of 30,000 and 70% of them was neutrophils, and the CRP was 400 with a urine pneumococcal antigen which came back later as being positive. This is his chest x-ray on admission, and the next day his chest x-ray showed completely white left lung with the mediastinum being pushed to the right, and you can see that the heart border is actually on the right chest now. This required a chest drain which drained 250 mils of this serous fluid, and the results of which we got later was the blood culture grew Streptococcus pneumoniae, which I asked the lab, I called the lab, asked them to send for serotyping, and they sent it to IMR, and it was serotype 14. It was sensitive to ceftriaxone, which he was already on. The pleural fluid had no growth, but the pleural fluid for pneumococcal conjugate vaccine was positive. So this child spent 15 days in hospital. Parents spent almost 18,000 ringgit during that time. Not to mention that the parents were off work for 2 weeks. Fortunately, the father dealt with work for online. There was anxiety and stress because of ICU stay, the chest drain and IV antibiotics, the pain and the scar, and the risk of nosocomial infection. The emotional trauma, which the baby was very clingy, fearful, and every time they drove past the hospital, the baby would cry. So this caused an emotional burden on the child, and they could have saved this with the benefit of spending almost 1,000 ringgit for 4 doses of the vaccine, and without all of the emotional baggage. So this is just to show you the burden of disease, the burden on one family. Now, the long journey from for the introduction of the pneumococcal vaccine in the NIP started way back in 2005. As you know, the Prevnar was first introduced in the US in the year 2000. In 2001, I actually wrote an article about the pneumococcal vaccine in our newsletter, our Malaysian Pediatric Association newsletter called Berita MPA, and not knowing that 5 years later I'd be involved in this long journey. Now, this started with the launch in May of 2016 with a celebrity, as you can recognize. She's for Dr. Nitin Shah's sake. She is Sheila Majid, a famous singer. And from there, we actually went on to give talks and workshops all over the country to tell pediatricians first about what pneumococcus is and what pneumococcal and that the vaccine is available. And then we went on to spread it out to the public by newspapers. And we had this advertisement that came out from the Pediatric Association, which we were initially criticized for being fear-mongering. So we changed it to something less severe. And then eventually we said the company should just do their own advertising. So, and we also developed alliances within the region. This is by forming what we call the Asian Strategic Alliance for Pneumococcal Disease Prevention. And this involved countries alphabetically from China to Thailand, and then west to east from India, Pakistan, right up to China, Hong Kong, and Taiwan. And the first meeting was actually held here in 2007. So, and we actually published papers in vaccine on the disease burden of pneumococcus in Asia. And then locally, and also in the region, we had on this huge deluge of information that went out to the public on pneumococcal disease in all languages. And the result, and then and each of the countries held different activities at different times, with Thailand and also in the Philippines, where we had a walk for child rights and with carrying banners on pneumococcus. Now, The result of all that is that PCV was introduced in the National Immunization Program of Hong Kong in 2009, in Singapore, although in a limited scale in 2009, in Pakistan in 2012, and Philippines in 2012, in Indonesia, starting with 2 provinces in 2017, in India, as Nitin says, started in 2017, and they are scaling it up from the high mortality states. And of course, we have just got it in our country in 2020. So this is the journey that we took from the beginning in 2005, and then we started Immunize for Life, which is in 2013, that was launched by the Director General of Health, and this is actually an expert-driven program, and in it you'll find videos as well as information on vaccine-preventable diseases, as well as vaccines that are available. And you can actually go to www.ifl.my. And if you have patients who want more information, you can actually tell them to go to www.ifl.my, and they can get information on any disease, vaccine preventable disease there, as well as and get nice videos that they can learn from. So hopefully that you will tell your patients about it, or you can have a look at it today and see what it's all about. Now, this lady, her name is Chan Lee Jin. She attended the first launch of the pneumococcal vaccine where Dr. Musa and myself talked. And then she attended 2 years later another one on pneumococcus, and then she wondered why nothing was happening, and the government wasn't taking what we were saying seriously. So in 2013, she decided, let's do a Yes to PCV signature campaign. So she went around the country and got people, doctors, to distribute these signatures to their patients. And some of you who are pediatricians probably were involved in this, and I'd like to thank you for that. And she went around, and then we got 20,000 signatures, and we sent all of that to the then Minister of Health. And it was during this meeting with the Minister of Health that we brought a lady who had lost a child to pneumococcal disease, and a grandfather who lost his niece to pneumococcal meningitis, who happened to be Dr. Musa's patient. Now, during this meeting, Dr. Musa mentioned to the minister that this is your legacy to leave if you leave the department, the ministry with this vaccine. As we all know, nothing happened until we had the election, and then in 2019, the next Minister of Health put it in the budget, and we had it, and we are now getting it in, and we finally in 2020 we have the pneumococcal conjugate vaccine to be introduced in our NIP for our children, and it will be free to them. But there'll still be people who will go to the private pediatricians. Now, what were the data that we used to get that information to? Now, the incidence this is from a data from Southeast Asia. Now, in Malaysia, it's estimated that there are 384 IPD, invasive pneumococcal disease cases per year, and about 74 IPD deaths annually. And this is a paper from Dr. Lee Wei Sia, who looked at one institution, which is the University of Malaya Medical Center, and he looked at 15 children who were admitted with pneumococcal disease, and 76% of them were younger than 2 years of age. And the pattern of infection was pneumonia in 8, probable pneumonia in 33, and there were meningitis in 4, bacteremia without any focus in 4, and septic arthritis in 1. There were also pre-morbid conditions in these kids, and the complications ranged from seizures to pleural effusion and empyema, cerebral palsy, pneumonia, pneumothorax, subdural empyema, sensory neural deafness, and subluxation of joints in the septic arthritis cases. So pneumococcal disease is something that's serious that we need to actually take heed of. This is on vaccine preventable meningitis in a book that I managed to Catch is an expert review of anti-infective therapy that's written by Stuart Clark. And it reviewed a paper that was published by Dr. Hussein Imam, our previous head of pediatrics, that looked at 5 centers in the country. And he found that most of the meningitis cases were those aged less than 5 years old in 77% of them. And most of them were due to Haemophilus influenzae and Streptococcus pneumoniae, with Haemophilus influenzae making up 40% and strep pneumonia making up 20% of the cases. And 93%, and in another study, 92% of the children who got meningitis were also below 5 years of age. And another earlier study showed that there was a higher proportion of those in the first year of life, and with a case fatality rate of 20%. Now, this is a graph that shows vaccine preventable meningitis in taken from different papers from 1988 right up to 2008. You'll see the pneumococcus is in the zebra one, and Haemophilus influenzae is in the white polka dot one. So, we had HIP vaccine introduced in 2002. And in a paper that was published in 2008, you can see that the zebra pneumococcus actually went up, whereas the Haemophilus influenzae came down. So that just shows that the HIP vaccine was effective in controlling HIP meningitis. This is taken from a study by Dr. Swahimi and Dr. Asmiati in QE Hospital, Queen Elizabeth Hospital in Sabah. He looked at, what he did was he looked, you know that the HIP vaccine was introduced in 2002. So what he looked at all the cases of meningitis from January 1999 to December of 2001, and compared it with January 2004 to December 2006. So you have 2 years before and 2 years after the thing, and you find that there is a significant drop in Haemophilus influenzae as shown in this graph, and a significant increase in pneumococcal meningitis because of the drop in Haemophilus influenzae. And you can see that most of the cases occurred between a year and 3 years of age. And he calculated the incidence of meningitis per 100,000 children population in that area, and it was 21 per 100,000 before the HIP vaccine for HIP, and 2.9 after. But for Streptococcus pneumoniae, it was 3.7 per 100,000 and increased to 8.6 per 100,000 children aged less than 5 years. So we have another problem here with meningitis caused by pneumococcus. Now, I mentioned earlier that the vaccine is very serotype dependent. So that I cannot go on talking further without going into the various serotypes. This is taken from a paper by Dr. Rohani in 1996, and looking at for a period, looking at the isolations of Streptococcus pneumoniae in Institute for Medical Research here. And she found that 65% came from children aged less than 2 years. The main serotypes are the ones in blue, but the serotypes 1 and 19B were the most common serotypes associated with invasive disease at that time. And the resistance to penicillin was about 7 to 1.1%, and erythromycin at that time. This has gone higher. And as you can see, it is the 2 peaks of age that has high incidence of both invasive and non-invasive pneumococcal disease. And when you look at the common serotypes in the country, it was mainly 19A and 19F, 6A and 6B, and then 14 and 1 and 23F. Okay, you just keep these numbers in your mind for a short while. This is in 2008 and 2009. Now, I mentioned earlier that there is a temporal variation in serotype. So Here you can see that from 1995 right up to 2009, there is a difference in the incidence of the distribution of serotypes. Like 19A was non-existent almost in earlier, but in 2008 it went up, and there were more now in the later ones, 2014, 2017. 6A had up and down as well. Now one was high in the beginning, but it dropped and then it came up again in 2008. 19F has always been in the background, and so 6B. So, and when you look at, you narrow it down, the most common serotypes are these, but what's more important is the invasive isolates, which are 6A, 6B, 19A, 19F, 14, and 1. Remember that my patient was serotype 14 earlier. Okay, and this is the invasive pneumonia. This is taken from a paper in published in 2018 by Dr. Rebati from IMR also, and she found that the most common were serotype 14, 6B, 19A, 6A, and 19F. So if you will, and you compare that with the previous one in 2008, 2009, the only serotype that has almost disappeared is actually serotype 1. All the rest actually remain the same as these. And this is the number, these are the serotypes that I mentioned earlier, 6A, 6B, 19A, 19F, 23F, and 14. And these 6 serotypes cover almost 80% of invasive isolates in Malaysia. We're talking about Malaysia, right? So how does it cover with the vaccines that are available? For PCV7 or the original Prevnar, it covered 63.3%. For PCV10 or the Synflorix, it covered 64.1%. For PCV13 or Prevnar 13, it covered 88.2%. So now you're wondering what's the coverage for 10-valent PCV or Pneumosil. It's actually 83%. And what they did was actually to remove serotypes 4 and 18 and replaced it with 19A and 6A, right? So I've mentioned to you about 19A and 6A before, and this is the composition. 6A and 19A are not present in Synflorix, and 3, 4, and 18C are not present in Pneumosil. So what about these serotypes 3, 4, and 18C? These are serotypes that are prevalent in Western countries. Serotype 3, for example, is the second most common serotype causing IPD in Europe, and serotypes 3 and 18 are amongst the top 3 serotypes in many European countries like Sweden, Switzerland, Germany, Austria, and Finland. And together, these serotypes contribute 16% of IPD cases in American children, but it only contributed 3.2% in Malaysian children, these 3 serotypes. So the prevalence of serotypes 3, 4, and 18C is actually low in Malaysia. So you can see from this table, you can see that the prevalence in the USA compared to in Malaysia. And you can appreciate that 3, 4, and 18C actually do not, for the time being, make much difference here. So, and as far as the world is concerned, the coverage will be for Asian countries in the whole region will be about 68%, for Africa 62%, Latin America 74%, and India 71%, 73%. So globally 71%, and India is 73%. So this is a vaccine that's made for the developing countries. This is a Pneumosil vaccination schedule. It's a 3+1 vaccine, 3+1 schedule with 3 in the first year of life, and then booster at the end of it, 2 months apart, and then at least 4 to 8 weeks apart, and then at least 6 months before the next dose. And if the child is, this is exactly like the PCV13 schedule, except that you can only use this up to the age of 2 years for the time being, because there are no studies to show. Now, this is Pneumosil is a pre-qualified, WHO pre-qualified vaccine, which means that it has submitted all of its data to WHO, and it can now be purchased by the United Nations and Gavi, and so they have had all the data which have been phase 1 and phase 2 studies in India and Gambia, and then also comparing with Prevena and comparing with Synflorix, and they also have phase 3 clinical trials in Gambia as well as in India, where they compared with Prevena in Gambia compared with Synflorix to show non-inferiority with these existing vaccines. And the ongoing or proposed clinical trials will be involving trying the 2+1 schedule in India and Gambia, and then post-licensure impact assessment, as well as other safety issues that hopefully they also come up with herd effect. So the Gambia study is actually comparing Pneumosil and Synflorix with a total number of subjects of 2,250 infants. It's a randomized, phase 3 randomized double-blind study to evaluate the safety, tolerability, lot-to-lot consistency, and immunogenicity and non-interference with concomitant vaccinations of Serum Institute India 10-valent vaccine compared with Synflorix. So you can see from this is the post-primary, the IgG that met more than the WHO criteria of 0.35 microgram per mil in terms of immunogenicity. You find that Pneumosil was non-inferior to Synflorix for all of the 10 serotypes, and then if you look at the post-primary, okay, this is from IgG, right? And then if you look at the opsonophagocytic activity, which is the functional activity of the vaccine, you will find that these are titers taken for comparing Pneumosil and Synflorix, and you look at the purple one, which is Pneumosil, you find that the OPA titers for the 6 serotypes were significantly higher for Pneumosil, right? For 1, 5, 6A, 6B, and then 19A and 23F. But 19A and 6A are not there, so you cannot really count that. It's not in Synflorix. And post, this is post booster, right? After the booster of GMC of the vaccine, you find that the post-booster GMCs were significantly higher for Pneumosil for serotypes 1, 5, 6A, and also 14 and 19A and 14. 19A you can discount it because it's not in Synflorix, but 14 also higher, and also it was also higher in 6B and 7F, but it's higher for Synflorix in 23F and 19F. Okay. Now, these are the opsophagocytic titers, the functional titers. You also find that there was no serotype. There was no serotype was significantly higher for Synflorix for the booster OPA response. So all the OPA response, the functional response, were higher for Pneumosil as compared to Synflorix. And this is taking 10 years after. 10 years after the vaccine, you find that there's still IgG geometric mean concentrations were higher in Pneumosil group for 6 out of the 8 common serotypes, right? As well as for serotype 6A and 619A, which I said were not present in Synflorix. Similarly, the persistence of the OPA response a year later also showed very high zero responses for Pneumosil. Okay. All right, and these are the percentage responders 4 weeks post dose 3 when you compare 3 of the vaccines, Prevena, Pneumosil, and Synflorix. And you can find that the functional responses were high for all of them. and this shows the non-inferiority, but it also shows some superiority in some of the serotypes. And the IgG responses are also similar. For Pneumosil, the percent response for serotype 1 and 7F were at least 98%. And so these are, they are pretty similar. A bit of 19A, as I said, it's not in synfloric, so you can expect it to be lower in 19A in synflorics, but the rest of it, they are comparable. So with that, I'm just going to show you what our National Immunization Program looks like. This is what it looks like now, where we have the hepatitis B here, and then the DTP and so on given 5 in 1. But it's going to change in that we're going to stop giving that. So we're going to have 6 in 1 at 2, 3, 5 months, and then a booster at 18 months. And we are also going to have the PCV being introduced at 4 months, 4 months, 8 months, and 4 months, 8 months, and a booster at 15 months. So what are the newer PCVs in the pipeline? You know about 7, 10, and 10, 10, and 13. There's also 14 that's in the pipeline, and MSD is doing a PCV 15, and they will include an addition 22F and 33F, which actually isn't present in this country. And then Pfizer is also working in a 20-valent. This slide was actually taken from Dr. Nitin. You can see his name there. And I'd like to thank him for passing me this slide. So, Pfizer has got a 20-valent one, but you have to remember that the more you add the valency to the vaccine, the less effective the original ones become. So these are the take-home messages. Number 1 is pneumonia is common. Approximately half is caused by pneumococcus. Pneumococcus also causes other diseases, as I mentioned, meningitis, bacteremia, septicemia, otitis media, and sinusitis. And pneumococcal vaccine prevents pneumococcal disease, obviously. Pneumosil is the latest PCV that's available to us. The coverage is 83% of Malaysian serotypes. It is a cheaper alternative without compromising coverage. And just to remind you, the MOH will have 2 new changes to the NIP, which are converting the pentavalent to hexavalent vaccine, and also addition of our very long-awaited PCV. So with that, thank you very much.